All right, let's go to this second rhythm. This is a Mobus type 1 winky back block. So let's look at this, and we're looking, so we have our P, then we have our QRS, we have our T, we have our P right here, this is our QRS right here, this is our T, and see where it gets longer. If we really measure this out, it's longer between the first over here to the second or to the third, and then all of a sudden we have our P, but we have no QRS complex. This is a Mobus type 1 winky block. It is an atrioventricular AV block that is in form of a second degree AV block characterized progressive prolongation of the PR interval on the EKG on a non-conductive P wave. So you have the P right here, and then you don't have a conduction, so you don't have a QRS after that. Non-conductive P wave, so you have a drop QRS complex. And occurs, so it kind of goes away, and then it's going to repeat. It's not just once, it repeats in a cycle. A second degree AV block implies you have a drop beats, and the drop beats mean you have the sinus node is fired, and the conduction went through to the AV node, it just didn't make it past the AV node. So second degree, the SA node fires, the AV node, it gets to the AV node, but you don't have it doesn't make it past that. The second degree AV block has a P wave without any associated QRS, which we showed you right here. All right, further discussion on these is the second degree AV block, winky block. The rate can be variable. You have a P wave with normal morphology with consistent PP interval. The P wave's doing its job, okay? The P is doing everything it should. The P is there, you're having the firing at the SA node. It's doing its job. The QRS is normal. It's the conduction, that's the problem, is the PR interval is progressively longer until one wave is dropped. The cycle begins again following that P wave. So you have conduction error. The rhythm is going to be considered irregular because you have P wave and you have extending longer PR intervals until you have a P wave with a QRS being dropped. Second degree AV block type 1 occurs in an AV node above the bundle of His. Is often transient but can be due to an inferior MI or digitalis toxicity. Treatment. There's usually not indicated as this rhythm usually produces no symptoms. So the rationale is conservative management is based on there's a low risk of this suddenly progressing where they're going to need a pacemaker. So there's low risk for progressing. So you do want to do is ongoing monitoring and follow-up with asymptomatic patients, reserving intervention with those with clear correlation or they have symptoms. So this would be your board question. If someone comes in, I don't know, they come in for foot pain and everybody gets an EKG going through the ER. So everybody's getting an EKG going through the ER. They have foot pain because they stubbed their toe and they got the EKG. And you see this block there. And so what do? You're going to shoot them up to the cath lab, or are you going to call the cardiologist? The cardiologist is going to look at you and probably say, no, we can follow this as an outpatient. So what the purpose of that board question is to stop you from doing harm, from saying we need to take this patient emergently to the cath lab right now, because we've worked through, this is a type 1. We do not need to do an intervention at this time. Now, do they need to be followed? Yes. So this would be a good board question. Talk more about third degree AV blocks. The atrial rate is usually normal. The ventricle rate is usually less than 70 beats per minute. The atrial rate is always faster than the ventricle rate. Excuse me. The P wave is normal with constant P intervals, but it's not married to the QRS complexes. So you can mark those off. If you have a question, you literally get a piece of paper and you get on your rhythm strip and you can mark out the P waves. The QRS may be normal and wide depending where the escape pacemaker is located on the conduction system. Conduction between atrial and ventricle activities are unrelated due to complete blocking of the atrial impulses to the ventricles. The rhythm is irregular. Let's go back to that real quick. So the complete block of the atrial impulses occurs at the AV junction, either the common bundle or the bilateral bundle of branches. You need to have a pacemaker distal to the block takes over and is able to activate the ventricle. So you want to have it after the ventricle, so that way it kind of takes over, so it's paced, so that way you want to form where they have a perfect union, where the top part agrees with the bottom part. So you're squeezing, the atrium is squeezing in time to the ventricle to receive it, so the ventricle can squeeze out to the body. What can cause this? Digitalis toxicity. So digitalis pretty much in all these blocks. Acute infection can cause this. So you can have infection in your heart, causing you to not be able to conduct. There's an infection in there. This can happen if someone has endocarditis. MI can happen. Remember, the tissue is broken. That's why we talked about this. So important is perfusion, getting that tissue, getting the oxygen, because this tissue can be broken. Once that tissue is broken, it's not going to conduct again. Degeneration of the conductive tissue. Can be in conductive tissue disorders having this. Treatment modalities include external pacing, which you can see. Remember, if you're going to pace somebody, please be kind and then give them something so that they, for pain, for analgesia, and so they don't remember this. It's probably not a thing that they want. And I've seen patients get paced without analgesia or without any type of medications for sedation. It doesn't look good, okay? So be kind to them, okay? You just think about that if you want to be shocked 60 times a minute. You can try it to yourself first. You can try atropine for acute symptomatic episodes and permanent pacemaking for chronic complete heart blocks. Now, every once in a while you will see is that if somebody comes in with a complete heart block, you may have your EP doc says, I think this is secondary to their beta blocker, we're going to say overdose, but they may want a beta blocker or calcium channel blocker washout period. They may say that, or they may go right away and take them into the lab and get a pacemaker placed. We talk more about the treatment third-degree heart blocks, remove and avoid nodal blockades. And what would you avoid? You want to avoid your beta blocker and calcium channel blockers. You want to support the MAP. This is something we're going to keep talking about, our mean arterial pressure. So what is a mean arterial pressure? It's 1/3 of systolic pressure plus 2/3 of diastolic pressure. 1/3 of systolic pressure plus 2/3 of diastolic, because you spend 2/3 of your life in diastolic. You spend 2/3 where your heart is resting, 1/3 where your heart is squeezing. You can give IV fluids. IV pressors can be given. You can reverse beta blockers with glucagon. What's one of the side effects when you give somebody glucagon? Anybody know? They throw up. They love to throw up with glucagon. Don't know why, but they love throwing up with glucagon. Be aware of that. You can reverse calcium channel blockers with calcium, and we'll have a discussion on what calcium channel blockers, when you have overdoses, either it can be intentional or unintentional, what you can do. And then pacing, as we discuss. Here we'll go again and discuss, and then the final thing is, the final fix is EP, getting EP in there and getting where they put in a device where they're going to synchronize each other. Here again, causes can be ischemic heart disease, as we talked about. What's another infectious process we can think about? Lyme's carditis. Lyme's carditis. So you can think about Lyme's disease as we're kind of connecting everything together. Remember, the patient isn't just in isolation alone. We're not just, they're just come in with a heart problem. Maybe the heart problem is secondary to an infectious disease. Maybe they had a catheter ablation. Hey, the patient says, I went to the EP lab 2 days ago and I've had this funny feeling since that. Maybe in the ablation went poorly and they went and they cut a little bit too much, or they had damage to the tissue of the heart. We've talked about these already as beta blockers, calcium channel blockers, and digoxin. All right, this is the rhythm you fear, okay? When you see this, this is usually not a good sign, okay? This is not a good day. It's ventricular fibrillation, okay? This is a life-threatening arrhythmia characterized by rapid, now I want you to look at these, chaotic and disorganized electrical activity in the ventricles. This is chaos. And there's chaos in the room too. There's chaos in the patient's heart, and there's usually chaos in the room. There's people running around, nurses, techs, hopefully providers running around, and you guys, it's a very chaotic situation for both the patient and for everybody involved. If untreated, leads to sudden cardiac death. Why is that? Why is it? Because what are you doing? Your heart is doing stuff, it's going like this, but it's not getting blood anywhere. Okay, it's like your hospital administrator. They're doing stuff, but they're not doing anything, really. There they are, they're doing stuff, they're telling you to do things, but they're not doing anything. They're not, and there's no action occurring. It's just all they're doing is talking a lot. Here it is, the heart's talking a lot, but it's not squeezing and getting blood to it. So this is a chaotic rhythm. Keep seeing this with irregular timing and morphology leading to hemodynamic collapse and cardiac arrest. Prompt defibrillation is the only cure, okay, is the effective treatment. Prompt, and why, and we'll talk about why prompt is so important, is the only effective therapy in terminating ventral fibrillation. That's why AEDs are everywhere, Okay, why is there ADs at the airport? On airplanes, why is there ADs at the children's daycare? Why is there at McDonald's? It's because you can save somebody's life with this. And you want to restoring an organized cardiac rhythm. Survival decreases, think of this, 10% for each minute defibrillation is delayed. Survival decreases 10% by each minute defibrillation is delayed. That's why these devices are everywhere, all right? And that's why it's so important that you hook up to these devices and to try to figure out what the rhythm is and if it's a shockable rhythm. All right, so let's talk more about ventricular fibrillation. Rate is unattainable. Why is the rate unattainable? Because you're doing this, but you're not getting anything to get a pulse, right? So it's unattainable rate. Now you'll see something up on the monitor, but it's really, it doesn't matter at that point because the heart is doing nonsense. That nonsense isn't conducting to the rest of the body. The P wave may be present, but it's obscured by the ventricle waves, okay? There's just nonsense going up on the monitor. There's nonsense going in the room. There's nonsense going in the patient's heart. The AQRS is not apparent. Its conduction is chaotic electrical activity. The rhythm is chaotic electrical activity. This arrhythmia results in an absence of cardiac output. The heart is just doing this, but it's not doing anything meaningful. It almost always occurs with serious heart disease, especially in acute MI. Let's go back to it real quick again. So what do we want to do? How do we want to treat this? Immediate defibrillation, and we have to do our ACLS protocols. So what is going to be our ACLS protocol? We're going to start chest compressions, getting those pads on, and then seeing if this is a shockable rhythm or not. And then while we're doing this, we need to see is there identification and treatment of an underlying cause that we can fix or get the patient planned for their next thing. In most cases, they're going to need to go where? Cardiac cath. They're going to need to go to the cath lab because they may have an ischemic event. A lot of times they'll have an ischemic event. All right. So we're talking a little bit more to the definitions. So this sustained VTAC is longer than 30 seconds. Sustained VTAC is greater than 30 seconds. Sustained VTAC is, non-sustained is going to be 3 beats or more, but lasting less than 30 seconds. So sustained is greater than 30 seconds. Non-sustained is 3 beats or more, but less than 30 seconds. That's kind of like a warning shot. It's like, something bad may happen. Let's start figuring out if the electrolytes right. Is there something we need to do? Then you have stable VTAC. So what would stable VTAC can be? You have is where you're having this rhythm, but you're also getting what? You can actually feel a pulse on this. This is when you consider amiodarone as a medication. Lidocaine can be a medication. Now, and then procainamide, this is third line it's used for VTAC, but this is mainly going to be for WPW. And we'll talk about this. But amiodarone. If amiodarone probably went today, if it was tried to go through the FDA, it probably wouldn't be approved, to be honest with you. There's just so many side effects. Now, is amiodarone a great medication? Yes, it is, but there has so many side effects to it. And half-life is so long. So what's your half-life on amiodarone? It's about 100 days. So we don't think about that. That's amiodarone's about 100-day half-life on it. It's huge. Now, it takes effect right away. It's a great drug, but it has a half-life of 100 days. So if you give somebody amiodarone and say they have liver disease, that's in there, or if they have pulmonary fibrosis, that sits in their body for 100 days. It's a long half-life. Now, you see some literature that says 90 days, but it's 90 to 100 days. Lidocaine, you don't see it used too much, but it's effective. What's the side effects with that? It can have CNS toxication, meaning that it can be, people can confused enough where they actually have to be intubated. And it can also cause bradycardia and hypotension. Remember, any antiarrhythmic medication like amiodarone can cause an arrhythmia. Amiodarone can cause bradycardia. So you can be treating somebody and the patient can have a side effect of bradycardia. Now, procainamide is third line. It's used mainly for WPW. What's the side effects of this is hypotension. Remember, any arrhythmia drug can cause any antiarrhythmic drug can cause an arrhythmia. You can have asystole, you can have fibrillation. It's more common when it's IV administration. You can even get a lupus-like syndrome with arthralgias, abdominal pain, arthritis, pleural effusions, pericarditis, fever, chills, myalgias. So defibrillation is going to be the key for treatment of these. Unstable ventricular fibrillation, remember the ventricle is having a seizure. The seizure is happening. So what's the treatment? Is shocking. Remember, every minute you delay, we're going to say it's a 10% increased risk of mortality. Now, let's talk about the cool people out there that want to do a pericardial thump. Does it actually work? Well, it can. It has to be immediately. Like if you saw it on the monitor and you hit them on the chest. Now, this doesn't give you a license to punch a patient in the chest, okay? It can be done. So when you punch somebody in their chest, not saying you do this, but in theory, if you happen to hit somebody in their chest, you're going to get 5 to 10 joules of mechanical energy to the heart. Now, remember, if you hit it initially, right when it happens, it takes less energy. So that's why when you're doing, say, when you're defibrillating, why do you go up in the joules that you're administering to the patient? Because it takes more energy as time goes on. That's why it's so important to have the defibrillators, the AEDs everywhere, is if it can be done quicker, less damage to the heart, and it can be, if it's done, it's more likely they can fix the problem and decrease the risk of mortality. So I guess the pericardial thump, not a license to punch the patient. I know some people want to punch patients in their chest. Is an option when there's a witness arrest and the defibrillator is not immediately available. Like say there people are fumbling with the pads. I guess you can gotta get away with it that way. You may get lucky. All right, so you've seen these guys before, and we're just gonna do a brief discussion on this. So we've talked about kind of doing pacing. And you can see this right here, and you can sync right here. See this button right here? That's a beautiful drawing by me. This pacer right here, okay? Synchronized cardioversion is timing the shock, okay? Well, we're talking about pacing right here. Let's erase that and go back and talk again. All right, let's erase this. All right. So we're getting this patient in, and we're putting the pads on, okay? And we turn this machine on, and we want to sync to the T waves. Why do we want to do that? Why do we always want to put a sync to that? Does anybody know? You want to shock on the T waves because it prevents VFib. So when you're shocking somebody who's not in VFib, it stops them from going into VFib. So if you ever seen, and unfortunately I've seen this, where somebody doesn't sync before they shocked, and it happens, everybody gets nervous and things happen. They didn't sync to the shock, and what happens is then they've gone from a bad rhythm to an even worse rhythm. And then you have more chaos in the room. So you have chaos in the patient's heart, they'll go to ventricular fibrillation, and you have chaos in the room with people running around. So the defibrillator is an electrical device used to counteract fibrillation of the heart muscle and restore normal heartbeat by applying a brief electrical shock. What's the mechanism? It depolarizes the myocardium and induces a temporary asystole. Now you may not see it in all cases, but it reduces, just kind of like the reset button on your computer, you're doing a little quick reset, allowing the pacemaker, the true pacemaker of the heart to take over. Now does it always work? No. In here we'll talk about the synchronized cardioversion. Now these are recommendations, okay, and these can be what the starting is, and some people do different, yes, but these are just kind of some recommendations that you can think of. Is unsynchronized cardioversion. For if it's on a monophasic, you mainly see biphasic in most hospitals now. You start at 200, go up to 300, 360. Atrial fibrillation, you can start on a biphasic at 100 and 120. So if you deliver the shock and it doesn't proceed with a successful event, you would go up. Atrial flutters can be 100, SVT can be 100. The procedure will be terminated by either successful revision to a sinus rhythm, or when it's determined that this isn't working by whoever is the provider in charge. And then either the next step would be is this patient's going to pass, or we need to get them to another intervention. Another intervention could be a cath lab, taken to cath lab. We have not been able to prevent the ventricular fibrillation. We're going to rush them to the cath lab. Maybe there's an uncontrolled ischemic event that we can open up the arteries so the patient can get better.